Over the years to 2030, the evolution of public health varied by location. Some states confined public health agencies, or PHAs, to provide only legislatively required or mandated services, like infectious disease control, restaurant inspections, and emergency preparedness, which limited efforts in prevention or community-focused activities. In other states, public health shifted away from clinical services and toward prevention, health promotion, advocacy, advanced analytics, and enhanced emergency preparedness. With the implementation of the Affordable Care Act, more than 90% of Americans had health care insurance by the end of the 2010s. During the same period, healthcare quality improved as the patient-centered medical home model was widely adopted. In this model, providers anticipated patients' needs by routinely analyzing large pools of data, including genomic data and biomonitoring data transmitted by the patient's smartphones and wearable devices. Cognitive computing tools, like IBM's Doc Watson, helped physicians provide better care. Widely adopted digital health coaches also helped people make healthier choices in their daily lives. As a result of these advances in coaching and medicine, there was far less need for PHAs to provide personal clinical services. In states where public health was actively evolving, PHAs sought to keep pace with big data and advanced analytics to improve coordination in disaster preparedness, response, and recovery, as well as ongoing public health improvements. These PHAs ensured that the electronic health records used by healthcare providers were interoperable and secure, and that the aggregations were accessible to PHAs. PHAs also strongly advocated for privacy and discrimination protections, which were ultimately put in place. Personal health information in electronic health records was thus effectively integrated with environmental monitoring, social media data, Medicare and Medicaid reimbursement data, motor vehicle records, employment records, and other government data. Most PHAs access the anonymized data through cloud computing services for health surveillance. Analyzing the increasingly larger and more diverse data, however, required well-trained staff who were private sector contractors and local accountable care organizations. In any case, the growth of increasingly complex and sophisticated analyses strengthened emergency preparedness, response, and recovery efforts, and improved PHA's ability to target community needs, to monitor health trends, to provide better forecasts, and to plan. PHAs collaborated with healthcare providers and private companies to improve public health analyses and the design of public health services and interventions aimed at individuals and behaviors. PHAs expanded their roles in emergency preparedness and response as the 2020s saw more frequent extreme weather events such as droughts, floods, and tornadoes. Vector-borne infection outbreaks such as Lyme disease and dengue fever also became more frequent and more severe. Many PHAs took advantage of the increase in games and simulations used by all age groups to foster community-wide use of these that better prepare their communities for disease outbreaks and other types of emergencies. Federal, state, and local health and other agencies, as well as nonprofits and the business community, got better at successfully coordinating their preparation, response, and recovery. In all, however, public health did not improve as far as people had hoped. Expectations of game-changing innovations in public health went unmet. Big data failed to transform society, as some people in the mid-2010s had expected. Genomic data rarely provided a smoking gun for health researchers working on a specific disease. Healthcare access had improved, but little progress was made on more influential determinants of health. In 2030, late-career public health officials can look back on a series of important successes for the field, and at the same time recognize that the field never made it as far as it should have. The consensus is that public health made gains, but the continuous rise in healthcare costs and increases in overall health, along with increases in disparities among racial and income groups, had limited these gains to baby steps. PHAs and public health leaders recognize that they still have a long way to go to improve the health of their communities and reduce health disparities.